Now the next topic we are talking is glycogen. How the glycogen is made, what is glycogen, why we are making it, how we are going to utilize it. These all the questions will be answered in this lecture. So first thing first, what is the glycogen is all about? See, when you eat the food, most of the time we are eating a lot of glucose, and that is basically I will refer as extra glucose, because all the glucose molecules which we are eating, they are not going to be consumed at the same time. They are not going to be burnt at the same time, because we don't want that much amount of energy. The amount of the glucose consuming we are consuming more. But liver is very smart. What the liver will do is, whatever extra glucose you are consuming, all these glucose molecule will reach in your liver, and the liver will say that, okay, these are the extra glucose molecules which are coming, and the liver will start conserving them. The liver will try to save this glucose molecule. So in the liver we have a special protein. On this special protein, we are going to attach these glucose molecules, and we are going to make a big molecule. These glucose molecules will be attached, and we are going to make a large molecule. This large molecule is referred as glycogen, and we are going to store our glycogen in the liver. So the liver is the one who makes the glycogen and will store the glycogen. Now once the glycogen is stored, see why we are storing it, because in future when we are going to go into fasting state, at that time we will be requiring the glucose and the energy. We can break the glycogen, we can get the glucose back, and that will run over the body things in our cells. The reactions will happen, we'll get the energy at the fasting state, and the liver is making the glycogen, it is storing the glycogen. And who will requires the most of the energy? It is the muscle. So what the liver will do is, the liver will say to the muscle that I am having a molecule, you can keep it with you. Whenever you want the energy, you can cut this molecule, that will give you the energy. You can generate the glucose molecules, the molecules which you can do the glycolysis, and you can do the you can get the energy. So the glycogen is synthesized and is stored in the liver, as well as then it will be stored in the muscles also. And some amount of glycogen can even be stored in the brain also, but mainly the glycogen is there in the liver and muscle. Some part is there in the brain also. This glycogen is also called as the animal starch, because this is how we are storing the carbohydrate in our body. How the plants store their carbohydrate, called as starch. And this is how we are storing as an animal the carbohydrate, is called as animal starch. In the liver, we have around 90 gram of glycogen, and in the muscle and the brain cumulative, we have somewhere around 250 grams. So if they ask, per 100 gram concentration, where we have more glycogen, means if I take 100 gram of liver and 100 gram of muscle, where you are going to get more glycogen? Obviously in the liver, because the liver mass is just 1 kilogram, 1 to 1.5 kilogram. So in 1 to 1.5 kilogram, the 90 gram of glycogen is distributed. Whereas the muscle mass, it is somewhere around 20 kgs, 30 kgs, and in that we have the 250 gram of glycogen. So the concentration of glycogen is more in the liver. So the per 100 gram concentration, if you take per 100 gram tissue and you see the concentration of glycogen, obviously it is more in the liver. How the glycogen will be made? Now to make the glycogen, see, we are having the extra glucose molecules, and these extra glucose molecules will be clubbed together. We are going to make a huge molecule. But there are two technical things that you need to understand. That first, if you want to attach the glucose molecules together, you have to make the glucose molecule sticky. If the glucose molecule will be sticky, then only they can club together. This is one thing. Second, if you want to attach the glucose molecules together, you require a base. On that you will attach the first glucose molecule, then you will attach the second, then you will attach the third, then the fourth, and likewise, right? So how the glycogen is made? We have to make the glucose sticky, and we will require a base also. The base that is going to be required to attach this sticky glucose molecule, this is called as glycogenesis. In the liver, we have a protein called as glycogenin. The weight of this protein is 37 kilodalton. 37 kilodalton. On this glycogenin molecule, we are going to attach these sticky glucose molecules. The sticky glucose, actually, the extra glucose, we are going to convert the sticky glucose, and these sticky glucose molecules are called as the UDP glucose. So we convert whatever is the glucose molecules we are having, we convert them into UDP glucose, the modified form of glucose. And now these glucose molecules will be attached together. When they are attached together, the direction of the bond that is going to be there between the glucose molecule, here, for example, this glucose and this glucose, both the glucose are there in the alpha form, and the first carbon is uniting with the fourth carbon. So what is the direction of the glycosidic bond here? In the linear sequence, the direction of bond is alpha 1, alpha 4. The first carbon is uniting with the fourth carbon. And why it is called as alpha 1, alpha 4? Because the glucose are in the alpha form. Do you remember what is the meaning of alpha and beta? Whenever the glucose is in the ring structure, it will be referred as either alpha or beta. So here we are having the alpha glucose uniting with alpha glucose. And when we are making this glucose molecule clubbing together, when we make a long chain, almost 11-12 molecules are attached, then we can't make a more long than that. Then we have to make the branches. And to make the branches, at the branching point, we have a special direction of the bond. At the branching point, the direction of the bond is alpha 1, alpha 6 at the branching point. And then again, we have the linear sequence. So if you have understood, you answer me the question that what will the direction of the bond here? Is it a branching point or linear sequence now? It is a linear sequence. And whenever we have linear sequence, it is alpha 1, 4. So only at the branching point, we will have alpha 1, 6. In the linear sequence, we will have the alpha 4. So this is the basic idea about the glycogen. Let's concise this data. Whenever we are in well-fed state, when you have taken extra meal, at that time, whatever is amount of the extra glucose you are having, these extra glucose molecule will be conserved by your liver. How the liver is going to conserve that? The liver is going to attach these glucose molecules together by making the glucose molecule sticky. It will be attached together, will make a long chain, a huge branched molecule will be made, and that is called as the glycogen. And this is how the glycogen looks like. So when it comes to the glycogen metabolism, actually we have to discuss two pathways: the glycogen synthesis and the glycogen breakdown. When it comes to the glycogen synthesis, it occurs in the fasting state or the well-fed state. Yes, glycogen synthesis will occur in the well-fed state. When you have the extra glucose molecule in the fed state, will make the glycogen. When you are in the fasting state, we are going to break the glycogen, right? The glycogen synthesis, this is called as glycogenesis, and the breakdown, it is called as glycogenolysis. That is called as the breakdown. So we have the glycogenesis and glycogenolysis. First, we are going to discuss the glycogenesis, how the synthesis happens. So for this, let's see here, when you are in the well-fed state, you are having extra glucose. So here we have the excess glucose. But I told you that how we are going to attach them together, we have to make them sticky. So we have to do some modification. What we do is, first, we need to activate this molecule glucose, so we'll give the energy. The ATP will come into picture, we'll transfer a phosphate group, and we are going to make a molecule that is called as glucose 6-phosphate. It's a very same reaction that you have did in glycolysis also. The first reaction of glycolysis, you give the energy glucose to glucose 6-phosphate. So the same is here also. The name of enzyme is glucokinase, because you are transferring the phosphate group and the ATP is coming into the picture. Now this glucose 6-phosphate, right now the phosphate is on the 6th carbon. Now we are going to shift the carbon, the phosphate from the 6th carbon to the 1st carbon. So now the enzyme, the product that we are going to generate is glucose 1-phosphate. And because we are mutating the site of phosphate, so the name of enzyme is phosphoglucomutase. Because we are mutating the site, so phosphoglucomutase. This glucose 1-phosphate, on the glucose 1-phosphate, we are going to transfer a uridyl group. When we transfer a uridyl group, the name of the enzyme is uridyl transferase. And now the product that we are going to get is called as the UDP glucose. And this is the sticky glucose molecules. So now you have converted the glucose into some sticky glucose molecules, and these are called as the UDP glucose molecules. Now it is time to attach them together. First you will make the branches, or you are going to make a linear sequence. Yes, first obviously we are going to make a linear sequence. So the linear sequence will be added up to 11 residues. We are going to attach the 11 to 12 glucose molecules. The UDP glucose molecules will be attached together with the help of enzyme. the glycogen synthase. And what is the direction of the bond? Alpha 1, alpha 4 or alpha 6 in the linear sequence, alpha 1, alpha 4. Once we will have a long chain, now we are going to make the branching point. The branching point, the direction of the bond will be alpha 1, alpha 6 via the branching enzyme. And this is how we make the linear sequence, then the branches, then again the linear sequence, then the branches, and this is how we are going to make the glycogen. And this glycogen will be synthesized in the liver, it will be stored in the liver, and some part of the glycogen then will be shifted towards the muscle also, because they also requires the energy in the fasting state more. So this is how the glycogen synthesis happens. This is the pathway of glycogen synthesis. This is called as the glycogenesis. Now we are going to learn the glycogenolysis, how we do the breakdown of the glycogen. First, I will tell you some little detailed part. Then we will come back to this pathway and we are going to superimpose the information here itself. This process is very easy. See, what you have discussed so far is the glucose molecule, how it has converted into glycogen. This is what we have discussed, and this is called as the glycogenesis. Now we are going to learn the glycogenolysis. Now what is written here, I will use it in a while, but first let's understand how the glycogenolysis is happening. The glycogenolysis. How the breakdown of the glycogen is happening. That is glycogenolysis. First you answer me that it is going to occur in which state? When you are in the fasting state or when you are in the well-fed state? When you want to cut your glycogen? We want to cut the glycogen when the person is in the fasting state. And this glycogenolysis will occur in two organs because the glycogen is found mainly in two organs. One is the liver and second is the muscle. These are the two tissues which is having mainly the glycogen. Here is the glycogen molecule and I want to cut it. To cut the glycogen molecule, I will use an enzyme that is called as the glycogen phosphorylase. Glycogen phosphorylase. This enzyme works if the vitamin B6 is there. And we are going to cut the glycogen from one end. We will start cutting the glycogen molecule. And when you cut the glycogen molecule, see here, for example, this glycogen phosphorylase will cut from here. And now this molecule has been separated out. This molecule it is not in the form of glucose. This is in the form of glucose 1-phosphate. Glucose 1-phosphate. I will tell you what is going to happen with this glucose 1-phosphate in a while, but let's do this continuous cutting. So the glycogen phosphorylase is the main enzyme that is going to cut the glycogen. It will cut the first glycogen from the end, then it will cut the first glucose, then it will cut the next glucose, then it will cut the next glucose. It will continue the cutting till the point, from the branching point, 4 glucose molecules are attached. From the branching point, if the 4 glucose molecules are attached, now the glycogen phosphorylase cannot cut anymore. This glycogen molecule cannot be cut. The glycogen phosphorylase has a limit that it can cut the glycogen molecules only till from the branching point. If the 4 glucose molecules are attached, till this point it can cut. After that it can't cut, because this is a limit of the glycogen phosphorylase. So this particular structure of the glycogen, this is called as the limit dextrine. This particular structure is called as limit dextrine. What is the meaning of limit dextrine? Limit dextrine means 4 glucose residue attached from the branching point. This is called as the limit dextrine. Now it cannot cut. So now what happens is there is a special enzyme comes that is called as glucan transferase. What this glucan transferase will do is actually it will take out of 4 molecule and will shift these 3 molecule to the nearby place. It is going to transfer the 3 glucose residue to the nearby place, and now it will look like this. You can see that the 3 glucose molecules has been shifted here, and now the branching point is exposed. The moment the branching point is exposed, now we are going to cut the branching point. When you are going to cut the branching point, we will use the enzyme debranching. We are going to use the debranching enzyme. Can you tell me what was the direction at the branching point? 1,4 or 1,6? 1,6. So the debranching enzyme is basically alpha 1,6 glucosidase. And we are going to cut it from here. The moment you are going to cut it from here, now this molecule will separate out. And this molecule which is separating out, it is in the form of glucose. It is not glucose 1-phosphate, it is glucose. Now again you have the linear sequence, and once you have the linear sequence, again now which enzyme will come, start cutting again? The glycogen phosphorylase. The glycogen phosphorylase will start coming and it will start cutting the molecule, and now again these molecules will start coming out. And these molecules which are going to come out, it will be in the form of what? Glucose or glucose 1-phosphate? Glucose 1-phosphate. Only when you cut from the branching point, the molecule that comes is the glucose. Otherwise, the molecule that is coming out is the glucose 1-phosphate. Now, what is going to happen with this glucose 1-phosphate? See, why you are cutting the glycogen? You are cutting the glycogen because you want the energy. You are in the fasting state. How you are going to get the energy? This glucose 1-phosphate can be converted into glucose 6-phosphate. 1-phosphate, 6-phosphate. You are mutating the site of phosphate. So what will the name of enzyme? Phosphoglucomutase. Phosphoglucomutase. And the glucose 6-phosphate then can convert into glucose. To convert the glucose 6-phosphate into glucose, can you tell me what is the name of enzyme that we have used in the gluconeogenesis also? Yes, what is the name of that enzyme? Glucose 6-phosphatase. Glucose 6-phosphatase. And this is how you are going to generate the glucose. So when you cut the glycogen, ultimately you are going to get the glucose back. And the cutting of glycogen was occurring in 2 organs. Can you tell me the name of 2 organs? The liver and muscle. This enzyme, glucose 6-phosphatase, it is only found in liver. Only present in liver. Means the glucose 6-phosphate can only convert into glucose in liver only. So if they ask that when you cut the glycogen, what is the last product of glycogenolysis in the muscles? In the muscle, the last product is glucose 6-phosphate. And in the liver, what is the last product? It is going to be the glucose. So glucose will be produced in liver. Till this point, we have the liver as well as muscle. So now the point is that we understand that if the glucose 6-phosphate converts into glucose, what to do with the glucose, we know that. But what the muscle will do with the glucose 6-phosphate then? Because the muscle can't convert, right, the glucose 6-phosphate into glucose. What the muscle will do? The muscle wants the energy. So what the muscle will do? The glucose 6-phosphate is an intermediate of the glycolysis. So in the muscles, the glucose 6-phosphate will go to glycolysis and will give the energy to the muscles. The ATPs will be generated to the muscles, right? So this is how the glycogenolysis occurs. This is how the glycogenolysis is going to give us the energy. Okay, so let's summarize it again. What we have discussed here is the glycogen molecule, and I want to cut it. The first enzyme that is going to start cutting the process, it is going to be the glycogen phosphorylase. It will start cutting and it will cut. The product that is going to come, is it the pure glucose or glucose 1-phosphate? Glucose 1-phosphate. And it will cut till the point, from the branching point, how many glucose residues are attached? 4. After that, the glycogen phosphorylase cannot cut. This is called as the limit dextrine. Then which enzyme should come? The glucan transferase. That is going to shift the out of 4 molecule, 3 molecule will be shifted to the nearby branch. And now the branching point is exposed. So now which molecule will come? The alpha-1,6-glucosidase. That is the debranching enzyme. It will cut. And now this is how, again, we will get a linear sequence. Again, the glycogen phosphorylase will come and will start cutting. And this is how the glucose 1-phosphate will be continuously generated. This 1-phosphate will convert into 6-phosphate. And the 6-phosphate can be converted into glucose only in which organ? Liver. So liver can generate the glucose from glycogen. But what the muscle will do? The muscle is not having this enzyme. So the glucose 6-phosphate will directly enter into the glycolysis and will give the energy to the muscles. This is called as the glycogenolysis. Let's write down this information in the same pathway here, where we have discussed about the glycogenesis. Here also we are going to write the glycogenolysis. See what happens. When you are in the fasting state, you are going to do the breakdown. What is the name of the main enzyme? Glycogen phosphorylase. Glycogen phosphorylase. The glycogen phosphorylase, it requires vitamin B6. And this is the rate limiting step of glycogenolysis. when you do the breakdown, you answer me the question, when you do the breakdown, the products comes in the form of glucose or comes in the form of glucose 1-phosphate. We are going to get the glucose 1-phosphate. Glucose 1-phosphate. Till the point we reach till this here. When the debranching enzyme is going to cut here, we are directly going to get the glucose. But what is going to happen with the glucose 1-phosphate? The glucose 1-phosphate can convert into the glucose 6-phosphate, and the glucose 6-phosphate can convert into glucose. And when you cut the branching point, yes, you are directly going to get the glucose. To convert the glucose 6-phosphate into glucose, we require one enzyme that is called as what? Glucose 6-phosphatase. And this glucose 6-phosphatase is only found in which organ? Liver. So now you will answer the question, what is the last product of glycogenolysis in the liver? In the liver, what is the last product? Glucose. But in the muscle, what is the last product? Glucose 6-phosphate. So this is how the glycogen is synthesized, and this is how the glycogen breakdown happens. Look this entire pathway together and try to answer one question, that there is only one enzyme which is common in both the pathway, glycogenesis as well as glycogenolysis. There is only one enzyme which is common in both the pathway, phosphoglucomutase. It is used in the glycogenesis as well as in the breakdown also, the phosphoglucomutase. Okay, so what are the facts to be remembered and how we are going to answer these MCQ? So see here, the glycogenesis, the rate limiting step of glycogenesis, it is glycogen synthase. Glycogenolysis, the breakdown, it is glycogen phosphorylase. For the glycogen phosphorylase, the coenzyme is vitamin B6. What is the last product of glycogenolysis in the liver? In the liver, we are going to generate glucose. But in the muscle, we are going to generate the glucose 6-phosphate. The glucose 6-phosphatase enzyme, is physiologically absent in muscle. Glucose 6-phosphatase is physiologically absent in muscle, and that is why the last product was glucose 6-phosphate. The only enzyme which is common in glycogenesis and glycogenolysis, it is phosphoglucomutase. This is how the things are going to happen. Now, let's understand one more thing here, and first understand the concept and then try to answer. See here. Can you tell me what is the net energy gain that happens when you do the anaerobic glycolysis? When you do the anaerobic glycolysis, what is the net energy gain? 2 ATPs, right? From the glucose, if you come all the way to the lactic acid, the net energy gain 2 ATPs, right? Glucose converts into glucose 6-phosphate, then it converts into this, ultimately pyruvate, and then pyruvate to lactic acid. So net energy gain 2 ATP. This is anaerobic glycolysis. Now see here, if we are having glycogen and you cut the glycogen in the muscle, what is the last product of cutting of glycogen in the muscle? Glucose 6-phosphate. And now from the glucose 6-phosphate, you do all this reaction, you do the anaerobic glycolysis, and ultimately the pyruvate and ultimately the lactic acid. How much ATP you are going to get? Look at this diagram and comparison, and you will get your answer. Normally from the anaerobic glycolysis, how much ATP you are getting? 2. But if you do the anaerobic glycolysis here, because you are starting the anaerobic glycolysis in this process, you are starting from which molecule? Glucose 6-phosphate. Normally you should start from glucose. If you start from glucose, you require 1 ATP. And because now you have bypassed this step, so the 1 ATP will not be used. So instead of 2 ATPs, the net gain now will be 3 ATPs. So they ask this question that anaerobic glycolysis gives how much ATP? 2 ATP. But if you are doing the anaerobic glycolysis by cutting the glycogen in the muscle, then from where you are going to start, actually you are not going to start from the glucose, you are going to start from glucose 6-phosphate. So you are going to save this 1 ATP. So the net gain will not be 2, it is going to be 2 plus 1 comes out to be 3, because the investment will be less of 1 ATP. So the same point is written here. The glucose, when we do the anaerobic glycolysis, the net energy gain is 2 ATP. But if we do the glycogen breakdown in the muscle, the product is glucose 6-phosphate, and from there if you do the anaerobic glycolysis, then it is going to be 2 plus 1 comes out to be 3 ATP. In fact, this is the only one of the pathway where you are generating the 3 ATP in the entire biochemistry. 3 ATP is generation. It happens if you do the glycogen breakdown in the muscle and then you do the anaerobic glycolysis from the glycogen, if you are doing the breakdown and which is followed by anaerobic glycolysis, you are going to get 3 ATPs. This is the only one reaction where you generate 3 ATPs. Now we have discussed that how the glycogen is synthesized and how it is metabolized. If there is some problem in the glycogen synthesis or the glycogen breakdown, the intermediates are going to accumulate in the body. And if the glycogen intermediates accumulates in the body, that is called as the glycogen storage disease. So how the glycogen storage disease is going to present to us. There are different types of disease because there are so many enzymes. If you look at the glycogen pathway, there are so many enzymes are there. If there is deficiency of any enzyme, an intermediate will accumulate, and that is called as the glycogen storage disease. So what are the various glycogen storage disease we have? When it comes to the glycogen storage disease, actually there are total 8 glycogen storage disease to be remembered. Although they are not all are important, but we need to remember the sequence, the type 0, type 1, 2, 3, 4, 5, 6, 7. The type 0 glycogen storage disease, it is due to deficiency of the enzyme glycogen synthase. If the glycogen synthase enzyme is not there, we can't make the glycogen. There is no glycogen. There is no glycogen means there is no glycogenolysis also. So that is type 0. It is 0 means there is no glycogen. There is zero glycogen. That is called as the type 0. Von Gierke. Von Gierke is the most common glycogen storage disease. It is seen in the children and it is the most common. It is due to deficiency of glucose 6 phosphatase enzyme. It's due to deficiency of glucose 6 phosphatase. Pompe disease. Pompe disease is due to deficiency of acid maltase. Cori disease, it is due to deficiency of debranching enzyme. Anderson disease, it is due to deficiency of branching enzyme. McArdle disease is due to deficiency of muscle glycogen phosphorylase. Hertz disease, it is due to deficiency of hepatic glycogen phosphorylase. And Cori disease, this is the type 7, it is due to deficiency of the PFK1. So these are the various enzyme deficiencies are there. These are all the enzymes which are used in the glycogen metabolism, and if they are deficiency as there, this is how they are going to present to us. How we are going to remember this list? See, particularly I am more interested that you should remember at least this much of data. These 6 disease you must remember. What is type 1, 2, 3, 4, 5 and 6. You can skip the type 0 or type 7. That is not very important. How we are going to remember that? We will use a mnemonic that is going to be ABCD. What is ABCD? If they say Anderson disease, it is due to deficiency of branching enzyme. Anderson disease is due to deficiency of branching enzyme. Cori disease is due to deficiency of debranching enzyme. If they say McArdle, M for McArdle, M for muscle glycogen phosphorylase. If they say her disease, H for her, H for hepatic glycogen phosphorylase. So we can easily remember ABCD, M to M and H to H. These two we will put some effort and we'll try to remember. Pompe is due to acid maltase and von Gierke is due to glucose 6 phosphatase. Now once we have remembered the name of the enzyme, then we have to see that how these patients are going to present to us. The overall the most common glycogen storage disease, it is the type 1. That is the von Gierke disease. And particularly in the adults, the most common is type 5. That is the McArdle disease. Okay, so now we are going to see how these patients are going to present. The clinical features particularly is important of the von Gierke and the McArdles. Starting with the first one, that is the type 1 glycogen storage disease called as the von Gierke disease. Von Gierke is due to deficiency of glucose 6 phosphatase. Glucose 6 phosphatase enzyme. See, this enzyme glucose 6 phosphatase, do you remember this is found in liver, muscle or both? It is only found in the liver. It is not there in the muscle. So it is only going to affect the liver, because if this enzyme is not there, it is not going to affect the muscle, because in the muscle already it is not there. This enzyme is physiologically not found in the muscle. So whether it is present or not present, it is not going to affect the muscles. So as this enzyme is physiologically absent in the muscle, so this disease will not affect the muscle, as this enzyme is physiologically absent in muscle. So von Gierke Von Gierke disease does not affect the muscles. Does not affect the muscle. Now let's see how the patients are going to present to us of von Gierke. It is going to occur in the pediatric age group. So, see, normally what happens when a child is there in the fasting state, say for example, the mother has forgot to give the meal to the child. If the child is in the fasting state, what is going to happen is in the liver we have the glycogen will be cut out. We are going to have the glycogen breakdown. If you cut the glycogen, with the help of enzyme glycogen phosphorylase, we are going to generate the glucose 1 phosphate that will convert into glucose 6 phosphate that will convert into glucose. And now this glucose molecule can easily come in the blood and that will maintain the blood glucose level. So normally in the fasting state, the child does not go into hypoglycemia because the liver glycogen will be cut, will generate the glucose and that glucose will come out. But to convert the glucose 6 phosphate into glucose, we require the enzyme that is glucose 6 phosphatase. And we are having an unfortunate child who is having deficiency of this enzyme. If there is deficiency of this enzyme, this reaction will not be able to happen. So when this child will be in the fasting state, and will try to cut the glycogen will cut till this point only, till the glucose 6 phosphate. And now it is unable to convert into glucose. So because it will not convert into glucose, so the glucose will be less and overall the glucose that is going to reach in the blood will be less. So this child, when this child will be in the fasting state, means in between the meals, this child may go into hypoglycemia. And because the glucose levels are less most of the time in this children, so the growth will not occur properly. The child will failure to thrive, will not be able to gain weight, they is going to be unable to thrive. Secondly, the hypoglycemia can lead to seizure, can lead to altered sensorium also, if the hypoglycemia is very severe. Plus one more problem that is going to happen is this glucose 6 phosphate, it is impermeable from the hepatocytes. It can't go out, the glucose 6 phosphate, it is impermeable. So what happens is this glucose 6 phosphate can convert into the lipid, can convert into uric acid. So this child will have more lipid, hyperlipidemia, there will be hyperuricemia. And if the lipid is more and the lipid and the uric acid that is accumulating, this child may have hepatomegaly also. If the lipid will increase more and more, if the lipid will be very much more, the patient, even because hyperlipidemia means the hypertriglyceridemia particularly, can lead to pancreatitis. So this child can have the pancreatitis also, because if the triglycerides are very high, that can lead to pancreatitis. So how the von Gierke patients are going to present to us? Von Gierke, it's going to be a pediatric patient. The question will be saying that whenever the child is going into a fasting state, means in between the meals, the child becomes irritable. The child goes into hypoglycemia. When you did the examination, he was having hepatomegaly, he's having hyperlipidemia, hyperuricemia. So what are the features? Because there is hyperlipidemia, so the child is going to have the dole-like face. The liver and kidney size will increase because there is more lipid accumulation is happening in the liver and kidney. They are going to become big. In the liver, even sometimes we can have the hepatic adenoma. Because of the lipid deposition in the kidney, the patient can have the renal failure also. And because the liver and kidney are becoming big and big, see, you and me, the abdomen is big. If we have even the hepatomegaly, it is not very much visible from outside. You need to palpate and then you have to see that whether the hepatomegaly is there or not. But in a child, the abdomen is this much only. If the liver and kidney are big, the abdomen will come out. So this child will have the protuberant abdomen. So here you can see the protuberant abdomen. When you will do the investigation, most of the time this child is having hypoglycemia, the glucose is less in the fasting state, and what is more is the lipid and uric acid. This is the von Gierke disease. So the von Gierke disease, the main problem is during the fasting state, the child is going to go into hypoglycemia. This disease is not going to affect the muscles because this enzyme glucose 6 phosphatase is physiologically not there in the muscle. So this disease is only and primarily going to affect the liver only, right? This is the first disease, the type 1, that is the von Gierke disease. Coming to the type 2, that is called as the Pompe disease. How the Pompe disease will come into action? The Pompe disease is due to deficiency of acid maltase. This enzyme is also called as the alpha-1,4 glucosidase. Actually, this enzyme, the acid maltase, this is found in the lysosome. Normally, this enzyme is found in the lysosome. So what happens is basically, normally the glycogen cutting is happening in the cytoplasm. When you do the glycogen breakdown, it happens in the cytoplasm. But some amount of the glycogen breakdown is happening in the lysosome also, particularly in the muscles. So what happens is, for example, here is the glycogen molecule. Normally, the glycogen breakdown is happening in the cytoplasm. There is no problem. But some amount of glycogen can go inside the lysosome also. And in the lysosome, we have the enzyme acid maltase that is going to cut the glycogen, and we are going to generate the glucose molecule in the lysosome. But if by chance there is deficiency of this enzyme, the reaction will not happen, and the glycogen is going to accumulate inside the lysosome, and the lysosome will get damaged. So anytime if there is accumulation of some substance in the lysosome, this is called as the lysosomal storage disease. So Pompe disease is a glycogen storage disease as well as it is a lysosomal storage disease also, because it is related to glycogen, so it's a glycogen storage disease, and it is affecting the lysosome also, so it's a lysosomal storage disease also. Normally, what are the lysosomal storage disease? We have the Hunter, Hurler, Sanfilippo. They were the lysosomal storage disease. They were the lysosomal storage disease because in that the GAG was accumulating in the lysosome. Here also in the Pompe disease, the glycogen is accumulating in the lysosome. So this is a lysosomal storage disease also. So let's write down this disease, this point, that Pompe disease is a glycogen storage disease as well as it is affecting the lysosome also. So as well as it is lysosomal storage disease. And now the glycogen breakdown, normally it happens in the lysosome, but this patient is not having. So the lysosome of the muscles are going to be damaged, and eventually that is going to damage the muscle. So Pompe disease is primarily going to affect the muscles. So this patient will have the proximal myopathy. There will be glycogen depositions are there in the muscle. So when you will do the biopsy, you can see the vacuoles are there, multiple vacuoles that you can see in the muscle biopsy. That is going to damage the cardiac muscles. Also, there is going to be cardiomyopathy. Because of the cardiomyopathy, you might see some changes on the ECG also. We might see QT prolongation. We might see PR prolongation, the PR interval prolongation. Normally, the QT interval, it is around 360 to 440 millisecond. So here it is going to be more than 440 millisecond. Normally the PR interval on the ECG, can you tell me what is the normal PR interval? 120 to 200 millisecond. So here the PR interval can be more than 200 millisecond because the cardiac muscles are disturbed. The one of the muscle that can be disturbed is the diaphragm also. So this child may develop the respiratory failure also. Tongue is also muscle. So this lysosomes are going to be having a lot of glycogen that is stored there. So the tongue muscle hypertrophy can be there, means there can be macroglossia. Macroglossia can be there. So these all the features, this cumulative picture is called as the Pompe disease. So Pompe disease is primarily going to affect the muscles because Pompe disease is related to an enzyme which is found in the lysosome of the muscle called as acid maltase, right? For the treatment of the Pompe disease, we are going to give the enzyme replacement therapy. The acid maltase which is available in the market, it is called as the Myozyme. We can give the Myozyme, that is going to be a type of enzyme replacement therapy. Normally in the lysosomal storage disease, we can try the enzyme replacement therapy, and here we are going to use the myozymes. Coming to the type 3 glycogen storage disease. When it comes to the type 3 glycogen storage disease, this is called as the Cori disease. And we have discussed one mnemonic ABCD. Cori is due to deficiency of debranching. So it is due to deficiency of the debranching enzyme. Do you remember how the process happens? The glycogen phosphorylase cut. Then ultimately the branching point is exposed. And the branching point, to cut the branching point, we require the debranching enzyme. If the debranching enzyme is not there, we can't cut the branching point. And this intermediate, see, normally when we cut the glycogen with the help of glycogen phosphorylase, you will cut. You will reach till this branching point. If you are unable to cut because the debranching enzyme is not there, if it is absent, we can't cut it. So now the limit dextrins will start accumulating in the body. So this Cori disease, in this the limit dextrins will increase. So this disease also called as the limit dextrinosis. And because we are unable to cut it, so glucose 1 phosphate will be less, the glucose 6 phosphate will be less, and the glucose will be less. Eventually the patient is going to develop the hypoglycemia. So when this child is when the child will be in the fasting state and will try to cut the glycogen, will not be able to cut the glycogen properly. It's not that the glycogen will not be cut at all. Some molecules of glycogen will cut, but some molecules will not be able to cut. We are going to stuck at the branching point. So the patient may have the hypoglycemia, but not very severe. So we have discussed two diseases where we can have hypoglycemia in the von Gierke as well as the Cori. The Cori disease will have the less severe hypoglycemia. So I can say it's a less severe form or less severe than von Gierke disease. In von Gierke disease, we have severe hypoglycemia. Here we'll have the mild hypoglycemia. So in any pediatric patient, if they say during the fasting state, hypoglycemia is happening. If the hypoglycemia is severe, it is going towards von Gierke. If mild, it is going towards the Cori. If nothing is specified, mild or severe, they just say that the patient, the child, whenever he is in the fasting state, he is developing hypoglycemia, means they are talking about von Gierke. If nothing is specified, if they specified, then von Gierke, Cori. The next is the Anderson disease. Anderson disease, the mnemonic was ABCD. Anderson is due to deficiency of the branching enzyme. Branching enzyme is utilized in which process? Glycogen synthesis or glycogen catabolism? Yes, it is during the glycogen synthesis. So if the branching enzyme is not there, we will not be able to make the glycogen. The glycogen will be less. So overall, the glycogen synthesis will not happen. The breakdown will also happen less. So this disease will not have the much significant symptoms because the glycogen is not made at all. So the catabolism will also not happen. So that is called as the Anderson disease. There's nothing much question that comes from the Anderson as far as the clinical aspect is concerned. Now coming to the McArdle disease. McArdle disease is due to deficiency M for McArdle, M for muscle glycogen phosphorylase. It is due to deficiency of muscle glycogen phosphorylase. So what happens? See, glycogen phosphorylase is an enzyme of which process? Glycogen synthesis or breakdown? It is the enzyme of the glycogen breakdown. And when you want to break down the glycogen, when you are in the fasting state, when your muscle wants the energy, the glycogen breakdown happens. So let's take an example. There was an 18-year-old boy. His name was Rakesh. Now Rakesh has cleared the NEET UG exam and now he has secured a very good rank. Now he is going to go into the medical school after few months. Right now the counseling was going on. So what happened was Rakesh was thinking that after a couple of months he is going to go into medical school and right now he's having the free time. So he decided to go to the gym. He's thinking that he will have a good muscular body. So it will give a good impact when he is going to go in the medical school for the first time. So he has not told anyone in the family and he joined the gym. In the morning, he got up at 6 a.m. And he was going to the gym. To everyone's surprise, because Rakesh never gets up so early. And he got up on one random day, he got up at 6 and he's going out. So his parents asked that, where you are going, Rakesh? So Rakesh said, no, I'm just going to a morning walk. So he went to the gym, but he has not told anyone. He went to the gym and he did the physical exertion there. He went there and whatever the heaviest weight were there, he started doing the exercise with that. The muscle requires so much of energy. So the muscle will start cutting the glycogen. To cut the glycogen, we require the enzyme that is called as the glycogen phosphorylase. And the problem, this glycogen phosphorylase, with the help of vitamin B6, we are going to cut the glycogen. But the problem is Rakesh was not having this enzyme in his muscle. He was not aware because he has not done the physical exertion so aggressively earlier anytime. So what happened was he was having the deficiency of this enzyme. There was deficiency of this enzyme in the muscle. If this enzyme is not there, this reaction will not occur. The glycogen breakdown will not happen. If the glycogen breakdown will not happen, there is going to be no glucose 1 phosphate, there is no glucose 6 phosphate. And ultimately, the ATPs, the energies will be very less in the muscle. The muscle will be deprived of energy. The myocytes will die. The myocytes will be killed. The myocytes will rupture because the muscles are deprived of energy. So now he is going to have the severe muscle pain because the myocytes are rupturing. He did the physical exertion and within next few minutes he will have the severe muscle pain because the muscles are dying. Now he will put down the weights because he can't bear that pain and he will come to home. Now he is not going to tell anyone that he went to gym and so happened. He is thinking that everyone develops the pain when they go for the first time. But he was having the pain, and now what has happened in Rakesh? The muscles started rupturing, and when the muscle ruptures, the content of the muscle will come out. And one of the protein that is there inside the muscle, it is myoglobin. So the myoglobin will come out, and this myoglobin will go in the blood, and via the blood this myoglobin can go to the kidney, and this myoglobin can block the kidney tubules, and there will be damage to the kidney tubules. So when the Rakesh is going to urinate now, he will have the dark color urine because the kidney tubules are getting damaged, they were blocked. This entire picture is called as the McArdle disease. So in any MCQ, if you see physical exertion followed by muscle pain followed by dark color urine, it is going towards the McArdle disease, and it is due to deficiency of muscle glycogen phosphorylase. This enzyme works good if the vitamin B6 is there. So what you are going to give in the treatment, first you will try with the vitamin B6. If the vitamin B6 works, very good. If not, then you can give the enzyme replacement therapy. So we'll give the vitamin B6. If not working, then we can go for the enzyme replacement, right? So we have understood that the various types of the glycogen storage disease. If I just summarize them, what are the various types of glycogen storage disease we have discussed? The type 1, how we are going to make the diagnosis? They will say that there is a pediatric age group patient and he is developing severe hypoglycemia. That is the von Gierke. And along with that, there is going to be increase in the lipid level and increase in the uric acid also. The dole-like face, protuberant abdomen. Then we have discussed the type 2, that is called as the Pompe. In the Pompe disease, it is going to affect the muscle. It's going to affect the muscle, and it is a glycogen storage disease. At the same time, it is a lysosomal storage disease also. What is going to happen is, it is going to affect the muscle. It's going to affect the muscle. The patient is going to have the myopathy. It is also going to affect the cardiac muscle, the cardiomyopathy. There is going to be tongue hypertrophy. Tongue hypertrophy will be there. So basically, there is going to be problem with the muscles. And for the treatment, you will give the myozymes. Right? The enzyme replacement therapy you will do. Then we have discussed the Cori. Cori is the type 3. It is the mild hypoglycemia. Anderson, it is not very important. That is type 4. Then we have discussed the McArdle. Very important. McArdle, how we are going to make the diagnosis? They will say, whenever the patient is doing physical exertion, this is followed by muscle pain, and this muscle pain is followed by dark urine. This is the McArdle. So these are the hints which are there for the diagnosis of the various glycogen storage disease. Right? This is how the glycogen is metabolized, the glycogen synthesis and the glycogenolysis also. Let's understand the regulation of glycogenolysis. How the breakdown happens. See, we know that the product of glycogenolysis is glucose. When you cut the glycogen, ultimate product is glucose. So what are the various stimulators and inhibitors? First thing first, glucose is going to stimulate or inhibit. And what is going to happen with the insulin? The product is glucose. In any reaction, if the product is glucose, insulin will stimulate such process or will inhibit such process. The insulin is definitely going to inhibit such process. Insulin never wants the glucose to be made. Glucagon is opposite. Yes, it is going to stimulate. The cyclic AMP and calcium. Yes, they are going to stimulate. These are the stimulator only in the muscles actually. Cyclic AMP and calcium, they are the stimulator in the muscles. Actually, calcium directly does not stimulate. Calcium is going to increase the activity of the phosphorylase, the glycogen phosphorylase, and that is going to stimulate the glycogenolysis. Calmodulin is a molecule that may stimulate the glycogenolysis. Norepinephrine, they can also stimulate. Now, what else factors that can regulate this process? See here, when we do the breakdown, that is the glycogenolysis, when we do the breakdown of the glycogenolysis, what is the last product in the muscle? Glucose 6-phosphate. And what is the last product in the liver? Glucose. The last product in the liver, it is glucose. So what is happening is this glucose 6-phosphate and the glucose, ultimately they are going to generate the ATPs. They are going to generate the energies. So I told you one thing, that if the products are there already, they are going to inhibit the pathway. So what are the products of the glycogenolysis? What are the products of glycogenolysis in the muscle? If I ask you in the muscle, what are the products of the glycogenolysis? Glucose 6-phosphate and the ATP. And what are the product of glycogenolysis in the liver? In the liver, we have glucose 6-phosphate, we have the glucose, we have the ATPs. These are the products. So the glucose 6-phosphate and the ATP, if they are more, they are going to inhibit the glycogenolysis in the muscle, because they are the product of the glycogenolysis in the muscle. Whereas in the liver, who is going to inhibit the glycogenolysis? What are the products? Glucose, glucose 6-phosphate and the ATP. They are going to inhibit, right? The products, basically, whoever is the product, that is going to inhibit the process. The only difference is the glucose. In the liver, we can generate the glucose as a product, but in the muscle, we can't generate that. One important point that we have actually already discussed, that was, we have discussed two pathways. The synthesis of glycogen was glycogenesis, and the breakdown was glycogenolysis. There is only one enzyme which was common in these two pathways. Can you tell me which is the common enzyme in the glycogenesis and glycogenolysis? Phosphoglucomutase. Phosphoglucomutase. That was common in both. Now you use the knowledge of the previous lecture and try to answer this. It's going to be a difficult question, but let's give it a try. We have discussed a process called as gluconeogenesis. And right now we have discussed a process called as glycogenolysis. In these two processes, there is one enzyme which is common. Can you tell me which enzyme is common in both the pathway? There is one enzyme which is used in gluconeogenesis also and used in the glycogenolysis also. I am giving you a hint. That enzyme is only found in the liver. What is the name of that enzyme? Glucose 6-phosphatase. If you remember, the glucose 6-phosphatase was used in the gluconeogenesis also. I will just scroll up the notes for you. You can see here, just scrolling up for you, the gluconeogenesis. Do you remember? This was the gluconeogenesis. From the pyruvate, if you want to make the glucose, if you want to go all the way up, what is one of the enzyme that you are using? Glucose 6-phosphatase. So glucose 6-phosphatase was used in the gluconeogenesis, and just now we have discussed about the glycogen metabolism, and in the glycogenolysis we have used the glucose 6-phosphatase. So glucose 6-phosphatase is common in the gluconeogenesis and glycogenolysis. Glucose 6-phosphatase. I know it may be little difficult because right now you may not have revised the notes because that was just the previous lecture, so may not be knowing, but once you will see the overall picture, then you will understand all these things. The last point, when it comes to the glycogenolysis, can you tell me what are the various enzymes that you have used in the sequence? What is the first enzyme? Do you remember the diagram? You start cutting. What is the first enzyme? Glycogen phosphorylase. You will start cutting by this enzyme, glycogen phosphorylase. Then which enzyme will come? It will cut. From the branching point, how many molecules are left? Then it can't cut 4 molecules. Then which enzyme will come? Glucane transferase. That is going to transfer how many glucose residue? Out of 4, how many will be transferred? 3. Then the branching point will be exposed. Then which enzyme will come? The debranching enzyme. And then again the same sequence will be repeated. So in the glycogenolysis, these are the 3 enzymes which are mainly we are using. Then the same cutting is going to happen more and more, right? So this is all about the glycogen metabolism. In this chapter, we have discussed how the glycogen is synthesized. Then we have discussed how the catabolism happens, and if by chance, if there is problem in any of the enzyme, then ultimately how it is going to come to us. Let's solve some quick questions here. Glycogen is a polysaccharide. It is a polysaccharide of the alpha glucose. So polysaccharide of alpha glucose. It is found in 2 organs, liver and the muscle. What is the rate limiting enzyme of glycogenesis? For the glycogen synthesis, the rate limiting enzyme is glycogen synthase. Glycogen synthase. For glycogenolysis, for the breakdown, it is glycogen phosphorylase. The only enzyme which is common in both the pathway, it was phosphoglucomutase. Phosphoglucomutase. The glycogen storage disease which never affect the muscle, it is von Gierke disease, because that enzyme is already absent in the muscles. What is the name of that enzyme which is physiologically not found in the muscle? Glucose 6 phosphatase. Now here are the keywords. Von Gierke disease. What is the keyword? Whenever I say the von Gierke, what comes in your mind? Hypoglycemia. The fasting hypoglycemia in the child. Hypoglycemia in the child. Pompe disease. Pompe disease, muscle problem, the cardiac muscle problem, particularly cardiomyopathy. Cori disease. Cori disease, what is going to happen? A, B, C, D. C, Cori. Deficiency of D branching. What is going to accumulate? The limit dextrine, also called as limit dextrinosis. Anderson, it is due to deficiency of the branching enzyme. McArdle, the patient can't do the muscle activity, right? The muscle activity followed by pain, followed by dark urine. Do you remember, Rakesh? Yes, that is McArdle disease. So this is all about the glycogen metabolism, how the glycogen is made and how the glycogen is utilized. Now, before the next lecture, I want just to ask you a quick question from the chapter of isomerism. Remember, the formula of glucose was C6H12O6. The formula of galactose is also the same. What is the relation? They are isomer. These are called as which isomers? Epimer. And glucose and galactose, they are epimer at which carbon? Carbon number 2 or carbon number 4? Glucose and galactose, they are epimer at carbon number 4. This question we have already discussed actually. Now coming to the why there is in the diabetes mellitus there is fasting hyperglycemia. Why there is more glucose is there in the fasting state in the diabetes patient. Let me elaborate the question more. For example, what I am trying to make you understand it here is the representation of the blood. In a patient of diabetes, there is more glucose in the blood, right? The glucose level is more. Now I am saying that there is a patient of diabetes, he has not taken any meal for last 24 hours. There is no meal he has taken, he is in the fasting state. But still when we are checking the glucose, his glucose is coming high. See, normally though what happens is when you take the meal, the glucose goes inside and gets absorbed. And that glucose comes in the blood. In a patient of diabetes, the glucose utilization is not happening, so the glucose increases in the blood. But now I am saying that even the patient is in the fasting state. A patient of diabetes is not eating anything. Still his blood glucose is coming more. From where the glucose is coming in the blood? If he is not eating anything, from where it is coming? See, what happens is, in a patient of diabetes, the glucose comes from two areas. One, the glucose which he is eating, it is going in the blood and it is not getting utilized. And second, the glucose also comes from the liver, and that is via the process of gluconeogenesis. In a patient of diabetes, the gluconeogenesis occurs more. So there is more gluconeogenesis, more glucose production. So that is why even if a patient of diabetic, if he is not eating anything, his glucose level may be on the higher side. That is fasting hyperglycemia. So they ask this question that why there is fasting hyperglycemia in a patient of diabetes. Fasting hyperglycemia, it is due to increase in the hepatic gluconeogenesis. Hepatic gluconeogenesis occurring more. So we have discussed different pathways related to glucose and different pathways related to the glycogen. If I write down the 4 pathways that we have discussed so far, we have discussed one was the glycolysis, that is the breakdown of the glucose. Then we have discussed the synthesis of the glucose, that is the gluconeogenesis. Then we have discussed the glycogen synthesis, that is called as the glycogenesis. And then we have discussed the breakdown of the glycogen, that is glycogenolysis. What will the effect of insulin on all this process? And whatever is the effect of insulin in all this, the effect of the glucagon is going to be opposite. So let's answer them. First, in whichever process the product is going to be glucose, the insulin is going to inhibit such processes. And out of these four, can you tell me that in two processes we have the product is going to be glucose? In which out of these four the product is glucose? One, it is gluconeogenesis, and insulin never wants, so insulin is going to inhibit this. In the glycogenolysis, when you break down the glycogen, ultimately you get the glucose, so insulin is going to inhibit this process. Insulin is going to stimulate such process where you are beating the glucose, where you are destroying the glucose. That is the glycolysis. So glycolysis will be stimulated. And in glycogenesis, basically you are converting the glucose into glycogen. So overall the glucose levels are decreasing. So whenever the glucose are getting consumed, either the glucose is getting converted into pyruvate or the glucose is getting converted into glycogen, all such process will be stimulated by the insulin. Whereas the glucagon is going to be opposite. Whatever the insulin is going to stimulate, the glucagon is going to inhibit. And whatever insulin is going to inhibit, the glucagon is going to stimulate. So we don't have to remember actually glucagon, we'll just remember the insulin, the opposite is for glucagon. So that is basically is the summary that is there. And now you answer me one more question, that these processes occurs in which state? For example, glycolysis will occur in well-fed state or fasting state. Glycolysis, breakdown of glucose. When you will break down the glucose? When you have more glucose. So it is occurring in the fed state, the well-fed state. Well-fed state. Glycogenesis. Glycogenesis, you are making more glycogen. When you will make the glycogen? When you have extra glucose, means in the well-fed state. Well-fed state. So in the well-fed state, these two processes are occurring more. And who is stimulating them? Insulin. So if I ask you that in well-fed state, which hormone is more? Insulin is more in the well-fed state. In the well-fed state. Whereas these two processes, the glycogenolysis, the breakdown, it is occurring in the fasting, and the gluconeogenesis, it is also occurring in the fasting state, and the glucagon is stimulating these processes. So glucagon is more in the fasting state. Insulin is more in the well-fed state. And it is very easy to remember also, when you eat food, to digest the food, to digest the glucose, the beta cell secretes insulin. So insulin is secreted more in the well-fed state, and the glucagon will be secreted more in the opposite, means in the fasting state. So if I tell you that, let's make out the ratio. The insulin glucagon ratio. The insulin glucagon ratio is more or less? That will depend on the amount of the insulin. Can you tell me that? Insulin glucagon ratio will be more, means insulin is more. In which state? In the well-fed state. When you just have taken the meal, in the well-fed state, this ratio will be more. And this ratio will be less, means the insulin will be less when you are in the fasting state. So they ask these questions. This table is basically on the regulation part. If you understood has the core concept, that you just have to see that what is the ultimate product, what you are doing in the reaction. You are cutting the glucose or you are making the glucose. If you are cutting the glucose, well, good enough, the insulin is going to support you if you are cutting the glucose. But if you are making the glucose, the insulin will never support this. This is the first concept. Second, insulin will be secreted more when you are eating the food. When you eat the food, the insulin comes. When you are in the fasting state, the insulin will be less, right? So this is all about from the metabolism of the glycogen, right? Thank you.